Perfect. So some housekeeping things. First of all, my name's Cathy Verlinda. I'm the Director of Clinical Services for Accountable Healthcare. I've been a nurse for 34 years, and I have taught EKG rhythm interpretation, and I'm also an ACLS instructor. My background is critical care and ER, which open heart is my love, and that's how I got involved in teaching rhythm interpretation. We are going to be recording this session today, which is what main reason I have you on mute. So because this is a conversation, I don't just sit here and talk at you. I will call on people to help with the rhythm interpretation. And then I'll pause for a moment after I call your name and wait for you to get your phone off mute. Anybody at any time can jump in with a question on any particular rhythm strip. I just wish, just let me know that you're on the phone, who you are, identify who you are so I know who I'm talking to. Helps a lot if I know who I'm talking to. You should have received attachments to this notification for the link to do the rhythm interpretation today. And included in those handouts is a heart block poem. For those of you that struggle with heart blocks, this may help you. So I encourage you to just review it and see if it's of any help. And we can discuss this poem when we're working on our heart blocks, because we do have multiple ones of those. There's another attachment that goes over the ANOVA test requirements. And I just want to be clear with everybody what their expectations of you are. There is a study guide also attached. I highly encourage you to use that study guide. If you review everything that's in that study guide, you will pass their test. It's very thorough, it's simple, direct, and to the point, and I think it's put together very well. They require that you pass with an 85%. There are lethal rhythms in the test, and I'll go over this one more time with you at the end. VTAC, torsades, VFib, asystole, and pulseless electrical activity. If you fail to identify any lethal rhythm, it's an automatic fail. If you fail the test, your contract is automatically canceled. It's important that you know that. That's why we're doing this extra study session with all of you. There's 20 questions on the test, and it's 5 points for each question. Included on this ANOVA test requirements page, there are some online review courses that you can do too. You know, the way you become an expert and do a really good job interpreting rhythms is by practice, 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 looking at it over and over and over again until it makes sense to you. I'm not going to go over everything else that's on here because it's not pertinent to what we're going to be doing today. Are there any questions so far? Okay, no. I'm going to start with roll call. I want to make sure who's all on the phone, and I want to get to know you a little bit. So I'm going to start with Eleanor.
Hi, I'm here.
Hi, Eleanor. So you work on oncology?
I do, yes.
Okay.
So not a lot of rhythms, to be honest.
Okay, that's what I was going to ask you. How much rhythm interpretation have you done?
Little to none.
Okay, got it. Just keep in mind that the test you're going to be receiving is very basic. Okay? And that's part of the reason why we do this rhythm interpretation course with you, so that it enhances everything that you're going to be going over in the study packet. I can't emphasize enough. Create the time to do this study packet, and you'll pass the test. Okay. What are your other concerns?
I mean, really, that's it. I, know how to do an EKG, but interpreting it is just completely different.
Right.
So really just basics, and like you were saying before, the heart blocks when I was trying to study on my own were very confusing.
Right, and they can be. It's really a matter of breaking them down, and we'll go over that as we go through this session. Okay?
Okay.
Perfect. Thank you, Eleanor.
Uh-huh.
Kristen?
Sorry.
Hi, Kristen. You're med-surg?
Uh-huh.
And how long have you been a med-surg nurse?
15 years.
Wow, long time. How much rhythm
Yeah,
interpretation do you have?
minimal.
Minimal. Okay.
Yeah, just like the other girl said, I've done a lot of EKGs and things like that,
Uh-huh.
but not interpreting them myself.
Okay. Okay, perfect. So pretty much everything that I said to her, and it helps me to get to know you guys as we're setting up for this today because I know what level we're starting at with all of this.
Right.
Okay. Any other concerns going into this?
No, just I hate tests.
Okay. I don't like being tested either. back in back in back in nursing school days, I had to take a course on how to take tests. So
Yep.
yeah, I had to do that.
Yep.
Thank you, Kristen.
Thank you.
Amanda?
I'm here.
Hi, Amanda. So
Hi.
IMCU. How long have you been doing that?
This will be my first encounter with the MICU position. I have been working medical telemetry unit for the last, in cardiac for the last 5 years.
Okay, so you've got quite a bit of rhythm interpretation under your belt.
Yep, a little bit. I'm not
just a little.
but
What are some of your concerns going into this test?
I guess, when they say 5 points for each question, what kind of things are they asking us? What meds we're giving? I mean, what are all included in the 5 points?
It's very basic.
Okay.
They'll ask you to measure an interval, and then they'll ask you to interpret a rhythm, and that'll be one question. Then your next question will be, given what the above rhythm is, what would you do to treat it? And it's really very basic ACLS algorithm stuff. They don't want a long, drawn-out, answer. It's multiple choice. It's multiple choice.
Oh, it is. Okay,
yeah.
good.
Yeah. And it's really very basic.
Good.
Okay. Thanks, Amanda.
Yep, you're welcome.
Crystal?
Hello.
Hi, Crystal. So you're labor and delivery.
Yes.
And how long have you been labor and delivery?
7+ years.
Wow.
Yep.
Wow, that's quite a while. You've got a lot of experience behind you. How much rhythm interpretation have you had to do as a labor and delivery nurse?
Minimal, because we don't recover our own C-sections.
Oh, you don't recover C. Okay.
We did have to float to the unit where we had some med-surg overflow and joint camp. So we had some trouble with that, but we didn't interpret the strips a lot. There was a teletech that actually interpreted the strips every day for it.
So I'm glad you brought that up, Crystal. One of the things to keep in mind, we as nurses are responsible for what the teletech interprets. So let's say the teletech mounts a strip and does their interpretation, you have to sign off on it. Because at the end of the day, when you sign off at the bottom of all your charting and you're finished with that chart for the day, you're saying everything that's been entered into it is correct and that you've seen it. So even though you have a teletech, you're still the one that's responsible for that interpretation.
So the teletech would do it as an ICU nurse.
Oh, okay. That works then. If the teletech is a nurse, you're good to go.
Yeah, and then we were responsible for knowing the lethal rhythms, which was our main responsibility was.
Okay, perfect. Perfect. So you were responsible for, those. Any other concerns going into this?
No, it's just a little bit out of my comfort zone, so it's just
Got it.
studying and looking at it. So.
Okay. Okay, perfect. Thanks, Crystal. Irene?
Yes, I'm here.
Hi, Irene.
Hi.
ICU nurse, my fellow companion here. How long have you been an ICU nurse?
7 years.
7 years? Do you
Yes.
have any concerns about this test?
Not really.
Yeah, it's a good review. Yeah, it'll be a good review for you. I'll call on you for the complicated ones.
Okay.
Okay, Irene.
I have a problem for Tulsa point. and DC, some DC, they put them look different.
Okay. Okay. Okay, we'll go over all of that, okay?
Okay.
Okay, Irene, thank you.
You're welcome.
Michelle?
Michelle's not on.
Okay, Michelle's not here. I'll cross her off. Jess?
Hi.
Hi, Jess. So you're one of my other L&D nurses.
Yeah. I worked ICU the first 2 years of my career, but it's getting a little rusty. That was 6 years ago.
Okay.
So, but for the most part, I work at like high risk facilities. So I would say I see, we look at them. More commonly it's more lethal than blocks. But
okay, good.
I think for me, I just feel like it's always that like picture that looks different and in like the testing situation,
Right.
So I think if I sit down and look over everything, I feel better about it. It's just always that like anxiety about the test. So.
Right. Well, you know as well as I do, the better prepared we are for a test, the more comfortable we are with the test, right?
Yeah.
Yeah. And you've got until September 14th to study and practice. So.
Correct. Good.
Okay, Jess. Good. Perfect.
Thanks.
Perfect. Thanks. Jessica?
Yes.
Yeah, you're my other L&D nurse. I have 3 L&D nurses on here today. How much experience in L&D?
5 years.
5 years. Any rhythm interpretation?
Minimal. We do recover our own patients, but I don't come from a high-risk facility, so thank God most of mine have normal sinus rhythm in these recoveries.
Yeah. So let me ask this question. I checked with one of my nurses out of my branch here, labor and delivery, and she said what she experiences a lot is that the anesthesiologist is responsible for monitoring during the case, and if he notices anything that causes concern in the rhythm, then they call in ICU or they send the patient to ICU. Is that kind of what you experience?
Yes, that's exactly what we do.
Yep. Yeah. Okay, great. So I've got a snapshot of how it works for you. Okay, great. Well, thanks, Jessica.
Thank you.
Okay, well, we're going to get started. Does anybody have any questions or concerns we haven't addressed yet?
This is Amanda. I have just one quick question.
Yeah.
Do they give us a caliper there, or do we bring our own?
I've heard that they have calipers present on site, but I always recommend that if you have access to calipers, you bring your own, and then you know with certainty that you have calipers.
Okay, thank you.
You're welcome. Any other questions or concerns? Okay, well, let's get started. Next, I just went over all of this with you. The passing score is 85%. There's 20 questions. There's rhythm identification. You need to know how to do your measurements and basic treatment, and failure to ID even one lethal rhythm results in a failed test and canceled contract. Next. Okay, Jessica, let me start with you.
Okay.
Okay. Are you familiar with an EKG paper?
Yes.
Okay, and what all the little grids mean and everything?
Yes.
Okay. You want to talk us through how you use the EKG paper and the grids?
You mean with measuring or?
Mm-hmm. Yeah. You know, like what is each little square box? What's each big square box? The full strip.
Each little square box is 0.04 seconds, and each big box is 0.2 seconds. And then, so 5 big boxes is equal to 1 second. More than that?
That would be correct. 0.4, 0.2, yes.
Okay.
And then when you be sure to look for hash marks on the rhythm strips. If you've got 3 of them there, you know you've got a 6-second strip.
Okay.
Okay. Thanks, Jessica.
Thanks.
Next. this is how you measure your intervals, and it's important that you know these. Your PR interval normal is 0.12 to 0.20. Your QRS interval is 0.08 to 0.12. And your QT interval is 0.035 to 0.43. You do need to know these measurements. This is a great example of how to measure them, and you also have another one in your EKG packet. The main things you're going to be focusing on is anything that's abnormal. So, of course, in order to interpret a rhythm, you need to know these normal values. Any questions on your EKG intervals? Okay, next. Now, there are 5 steps to rhythm interpretation, and I'm sure a lot of you have seen this before. These are the golden rules. You follow these steps, you will always be able to name that rhythm. So you want to check in, what is the rate? Is it too fast or is it too slow? What is the rhythm? Is it regular or irregular? And the way you look to see if it's regular or irregular is looking at your R to R intervals. Is there a P wave for every QRS, and do they look the same? What is the PR interval? Are all of the QRS complexes the same, and what is the QRS length? Next. Okay, Eleanor.
Yes.
Are you there?
Yep, can you hear me?
Yeah, now I can hear you.
Okay,
let's
sorry.
take a look at that. Let's take a look at this rhythm strip and start dissecting it.
Okay.
Okay. So, what is the rate?
It looks slow.
Okay. Do you know how to calculate the rate real fast?
Is it the let's see, the QRS 1, 2, 3, 4, 5? Is that?
Yep. Yep. Exactly.
Okay.
So count the QRS complexes and multiply by 10.
Okay. And then it looks like there is a P for every QRS.
Yes.
And I don't know, that's about as far as I get. And then there's a T.
Okay. Okay, so there's a P for every QRS. There's a QRS for every P.
Mm-hmm.
What is the PR interval?
Let's see. I don't know if it's the picture, like am I just counting the, like the little boxes?
Well, this is a bad picture. Your PRs are within normal limits.
Okay.
You know, and your QRS looks like it's within normal limits too, right?
It does, yep, on mine.
Okay. So we've got a heart rate
of bradycardia?
Exactly. Exactly.
Okay.
Perfect. Okay, so you have a patient with sinus bradycardia. Her blood pressure is 88 and her SATs are 80. What are you going to do for this patient?
We'll put oxygen on her.
Yeah.
Let's see. Give her some fluids or blood.
Mm-hmm. Exactly.
Okay. I guess
well,
I'm thinking zebra.
Because you're and you're on an oncology unit, so of course you're going to be thinking, what's the underlying cause of this?
Right.
You know, she's sinus brady and she's sick. You know, you have to do something for her. You could give her some epi.
Okay.
Okay. Excuse me. One of the things to remember about epi is that it speeds the heart rate up. It doesn't solve your problem.
Okay.
You know, it'll give you time to think of what other interventions can I take. What would the dose of epi be?
0.5.
Perfect. Absolutely perfect. Good job. And Sam, do next.
And what? I'm sorry?
Oh, I was talking to somebody else. So we've got sinus brady here. So I'm going to give you a little tool to use. It might help you guys with medication dosages, and it might not, but it's one that I find is of value. when you're looking at your ACLS medications, if you have a beating heart, you cut all of the medication dosages in half. If you have a dead heart, you give them the full dose. Okay, Eleanor, thank you. Next. Kristen.
I'm sorry, I'm here.
Okay.
Like I said, I don't know. I'm learning this process on the telephone, and
I got that. I think all of us are. You know, I have to pause and allow you guys time to get back on the phone. Okay, let's take a look at this rhythm strip. First, what's the rate?
Fast.
It's fast, right? But how fast is it? Because that's the key to what you're going to be doing for this.
That would be 140.
Yep, 130, 140.
Okay.
So it's too fast, right?
Yep.
We're too fast. Is it regular or irregular?
Irregular.
It's irregular. Do I have a P for every Q or S?
Oh, yeah. Well, it's really hard to read, but not. It doesn't. Maybe not.
Maybe not. And why are you saying maybe not?
Because it doesn't appear like it has a P wave.
Right. It looks like it's fibrillating, doesn't it?
Yeah.
Yeah. I just gave you a clue. So what would this rhythm be?
I guess it would be AFib?
AFib, exactly. AFib with a rapid ventricular response.
Yep.
So the most important piece on this one is to find out the time of onset. Is this a chronic situation for the patient, or is it a new onset? Because you take different clinical pathways depending on time of onset. Your main goal with rapid atrial fib is rate control, rate control, rate control. So what medications are you looking at for that?
Well, you want to slow it down and control it. I'm trying to remember all the drugs that.
Right. Look at your beta blockers. All of your beta blockers. You know, so anything ending in OLOL is your beta blockers. And all you need to know is beta blockers. Okay?
Okay. Will they ask that, or will they ask specific drugs?
They ask specific. They'll ask. Sometimes it's a specific drug. Sometimes they'll ask, put down beta blocker.
Okay, so you have to know both the classification and the med.
Yep. But I'm helping you out on which ones you can do the classification or the meds with.
One of the beta blockers, whatever the policy has.
Just beta blockers is all you need to know.
Good.
So a golden rule of thumb with AFib. Anytime you have an irregular rate rhythm and you're trying to argue a case for whether you have a P wave or not, you're in AFib.
Yeah. Okay.
Guaranteed every time. Okay?
Okay.
Okay, next. There you go, AFib. Good job. Thank you. Crystal.
Yes, ma'am.
Next. Crystal?
Yes.
Okay, there you are. Okay, I'm going to help you to walk through this one. And I'm going to, let's first start with the rate. Is it too fast or is it too slow? Calculate the rate with me.
It's 80, so it's normal.
It's 80, right. Let's take a look at those PR intervals, because we've got a P for every Q or S, right?
Yes.
And we have a Q or S for every P.
Yes.
But what's our PR interval?
It's abnormal. It's too.
Yeah, it's about 0.24, wouldn't you guess? Yeah, it's about 0.24. If you can, when you're doing it on here, you have to kind of guess, put one over a square that looks like it's too long. So your PR interval is 0.24. What rhythm is that? PR interval is too long. So when you, first degree block, exactly. Perfect. Perfect. Now you could use atropine for this, but I wouldn't advise it because if you use atropine on a block, it sometimes will extend the block. So if this patient is symptomatic, you're going to be looking at pacing them until they can go and get a permanent pacemaker. So if you decide to transcutaneous pace your patient, what are you going to do to be really nice to me because I'm jerking every time I get a shock? I get a pace. You're going to sedate me, right? You don't want me to remember you.
Yeah.
Okay. Yeah. Next. See, there's your long PR intervals. And any other questions on that, Crystal?
No, I'm good.
Okay. Perfect. Thank you. Irene?
Yes.
Hi, Irene. Next.
Hi. Okay, I have to go to the
No, you're good.
Stream number 4.
Okay, here's rhythm strip number 4. So
yes.
How fast is this if you count each complex?
It's normal.
80. 80. Yeah.
Yes.
Right. Is it regular or irregular?
Irregular.
What's the rhythm?
It's AFib.
AFib, exactly. Heart rate of 80. Over half of the population over the age of 50 is walking around with this rhythm and doing just fine.
Yeah.
Next. Yeah, AFib. Good job. Thank you.
You're welcome.
Jess?
Yeah.
Okay, I called your name before I looked at the rhythm that was up here.
That's okay.
But we'll use all of the steps in rhythm interpretation. So the first one is, what's the rate?
50.
50. Is that too fast or too slow?
It's slow.
Okay. Do I have a P for every Q or S?
Yes.
Do I have a Q or S for every P?
Yep.
Is it regular or irregular?
Regular.
Regular. Okay, what about those P waves, though?
They're inverted.
Mm-hmm. What about the PR?
Oh, it's tiny.
Yeah, it's almost non-existent.
Right.
In fact, it's probably causing that QRS to have a little notch in it.
Okay.
Okay?
Uh-huh.
So, next. So what you have here is a junctional rhythm.
Okay.
Okay?
Uh-huh.
And all that means is that the P wave is not originating up in the atria where it's supposed to. It's originating closer down to the bundle.
Uh-huh.
That's all it means.
Okay. It's just called junctional rhythm.
Yep, and that's why it's called a junctional rhythm, because it's down in that junction.
Okay.
That's
it? Uh-huh.
Okay. Now, you probably won't see this very often, but now you know what a junctional rhythm is.
Yeah. That's good.
Okay, perfect. Thanks, Jess.
Thanks.
Jessica?
Yes.
Next. Ooh, Jessica, you get a good one right off the bat here.
Oh, lucky me.
Okay. At a glance, is this a lethal rhythm?
Yes.
Okay. What would you call this rhythm?
VFib?
Take a closer look. Is it really fibrillating? You do have some P waves in there. You can actually identify going across there. Next.
Oh, okay.
Okay. Yeah. So if you have the P waves, but they're not communicating anything, nothing's happening with them. What else? What do you have then? Next.
Oh.
Okay.
Okay.
Can you see that now?
I can now. I never would have gotten that right.
Yeah. Well, the thing you have to watch for is that if you look at those P waves, all except for the third one, they all do look very much the same.
Okay.
You know, and that's kind of a clue that this is ventricular standstill. It's not truly fibrillating. When we get to V-fib, you're going to see it looking like a true fibrillating.
Okay.
Okay. So what do we do for asystole?
CPR and cardio, defib them.
You've already got a dead heart. What does defibbing do?
Oh, just CPR, sorry.
Okay, so, right, and pacing.
Okay.
And you're going to have to find the underlying cause. What does defibrillating a heart do?
Like restarts the rhythm that they already have?
Right. So what it actually does is that it stops the heart. And we're hoping that by shocking it and stunning it into stopping, it will go back into a manageable rhythm.
Okay.
Okay, so that's why I said you've already got a dead heart. You shock it, you're going to make it deader.
Okay.
Right? Yep. So I just wanted to take you through that so you could be thinking about what's really happening when you do some of this. So definitely epi. And how much epi would you give?
0.5.
You've got a dead heart.
Oh, dead, 1.
Yep, 1 milligram. Perfect. And you're going to pace them, and they're already not going to be responsive to you, so you don't have to worry about sedating them any further, right? Okay, Jessica, thank you.
Thank you.
Okay, next. Eleanor.
Yes.
Okay, this is going to be a fun one.
Oh, great.
Okay. Well, it's one of the ones that you were worried about.
The heart blocks.
Yes, it is one of the ones you were worried about. So let's break this down. When you're dealing with a heart block, your best thing to do is to take every one of those steps, those 5 steps, and apply it diligently to the rhythm. I frequently will glance at a rhythm like this and go, oh, shoot. And then I go, okay, just break it down. So the first question is it too fast or too slow?
It's normal.
It's normal. Dang, okay. Normal rate. Is it regular or is it irregular?
Regular.
It's regular. Do I have a P for every QRS?
No.
Do I have a QRS for every P?
Yes.
Do I really?
I'm looking at the, I mean, they're all spread out.
They're all spread out.
Okay.
And so there is a pattern. There is a pattern to it if you look at it, right? If you look at the first complex, which is a PQRST, you can find one that looks similar to it at the end of the strip, but the PR interval is longer, if you want to say that's a PR interval.
Okay.
Okay, but we have P waves. Next. And we have QRSs, but they're not talking to each other, are they?
Nope, they're pretty far apart.
Right, yeah, I mean, they have no relationship to each other. So what rhythm would you say this is?
Is this the 1st degree heart block?
This is a 3rd degree heart block.
Oh, okay.
Okay. Now your first degree heart block is when the PR interval is greater than 0.20. You have an organized PQRS, and you have a P for every QRS, and you have a QRS for every P. It's just that the PR interval is longer than 0.20.
So is that the only thing that makes it first degree? Are those things that you just said? Okay.
Yep, those are the only things that make it first degree. You have an organized rhythm. Everything's normal on it except for that PR interval.
Okay.
But this guy, nobody's talking to anyone. They're like divorced from each other. The atrium and the ventricle are divorced.
Okay.
So this is third degree heart block because they aren't communicating with each other at all. So what do we do for third degree heart block?
I do not know.
You'll pace them.
Okay.
Pace them until you can get them into the cath lab to get the pacers that they need. Next. You are also going to support their blood pressure.
Okay.
Because you're not going to have a good blood pressure here. So you have to give them blood pressure support and try to get them transported as fast as possible. And hopefully you'll end up with a rhythm like this when they come back to you.
Okay.
This is a paced rhythm. Next. Next. Those are your pacer spikes. And that's what you hopefully will have your patient come back after a third degree heart block. Okay?
Okay. So when it inverts like that, that means it's been paced?
No, look at the pacer spikes going straight up and down.
Uh-huh.
Because all that all that an inverted QRS tells you is the lead you're in. So the deflection doesn't really mean anything. Because you can change that deflection depending on the view of the heart you're looking at.
Okay.
Which is determined by the leads of your EKG.
All right.
Okay, so those straight up and down spikes, the lines that you see, anytime you see those guys, you are in a paced rhythm.
All right.
Okay?
Okay,
good job.
Thank you.
Thank you. Next. And then Kristen, next.
Yeah.
Okay, you ready to go on a block?
I guess if I have to.
I had this patient.
Oh.
And it had me yeah, it was an exciting day. So, too fast or too slow?
Slow.
Yeah, slow. Do I have a P for every QRS?
For the QRSs that are there, you do, but you don't have.
You do. But you don't have a QRS for every P, do you?
Right.
So, based on that, what would you name this rhythm? If you don't know, that's fine. Just let me know. Next.
Yeah, I don't know. I'd say second degree. There you go. I was gonna have to say second degree because it doesn't fit 1 or 3. So.
Exactly. Perfect. Absolutely perfect. It doesn't fit 1 or 3. This is type 2. Mobitz type 2. So it's second degree AV block type 2.
Yeah, all I knew it didn't fit into the categories for 1 or 3, but don't know about the 2s very well.
Okay, so this is type 2 because in order for it to be a type 1 or a winky block, the PR interval would have to be getting longer, then you drop your QRS.
Right.
That's not what this one's doing.
Got it. Okay.
Okay. So what are we going to do for this patient?
Well, wouldn't we shock them?
You want to pace them? Think about what shocking does.
Oh, well, I guess that's true. Okay. So yeah, you would want to pace them because you would want to increase the QRSs.
Right.
You're going with your Ps.
Right. Right. So You could give them epi, but all it's going to do is speed it up. It's not going to resolve your issue.
Okay, it's not going to fix
So
it.
right. So you're going to pace them, and you're going to support their blood pressure. And you're going to get them to the cath lab for a permanent pacemaker like yesterday.
Okay.
Okay.
Got it.
Okay. Okay, Kristen, thank you.
I have a quick question. This is Ellie. I'm sorry.
Yeah.
I'm looking at the heart block poem, and it says if some P's don't get through, then you have the MOVIT too. But it's all P's here.
Well, take a look
about this incorrectly?
No, you're not looking at. You've got, if you look at the beginning of the strip, you have a complete PQRST, and at the end you have a complete PQRST. You have got 3 P waves without QRSs.
Okay. So it's some QRSs don't get through then?
Correct.
Okay.
So the P wave's not causing a QRS. It's blocked from, because it's an electrical signal.
Okay.
Right? So that's what blocked means. You know, your P wave is doing its job, but that signal is getting blocked someplace to the QRS.
Okay, I think I was just taking the poem too literally, so that makes more sense. Thank you.
You're welcome. Okay. Chris, did I just talk to Crystal?
No, you talked to Kristen.
I talked to Chris. Okay, Crystal, let's go. Next. All of your names start with K's. What can I say? Okay, Crystal, let's take a look at this one.
Okay.
So what's the rate? Is it too fast or too slow?
It's normal at 60.
Yep. Is it regular or irregular?
It looks, it's irregular, but it has periods of being regular.
Very good. The main, your underlying rhythm is regular, right?
Yes.
Okay, perfect. Do I have a P for every QRS?
There's a P for every QRS, but not a QRS for every P.
Okay, so what rhythm are we in?
Second degree type 1.
Okay. Type 1, the PRs would have to be getting longer, wouldn't they?
Yes. So it would be
type
2.
Very good. Excellent, Crystal. Excellent. Now this is what a normal second degree heart block looks like, guys. I just like the first one because that was my patient, and it's an unusual second degree heart block. This is what most of your second degree heart blocks are going to look like. Okay? Good job, Crystal. Thank you.
Thank you.
Next. Next. Okay, Irene, you're up.
Yes, sorry.
Just name that rhythm.
Asystole.
Yep, it's asystole. Does everybody see that okay? Let me put it this way. If nobody can see that it's asystole, jump on the phone and let's discuss it. Okay, next. So Irene, what are we going to do for this patient?
You give epinephrine.
You could, but you know that you're going to try to pace that person and see if you've got anything to capture, right?
Okay.
Because that was, you didn't have anything much left to capture, but you could try it. And you can try epi.
Yeah, with us. Okay.
Okay.
Yes.
Okay, Irene. Thank you.
Thank you.
Jess?
Yeah.
Hi, Jess.
Hi.
Okay. Take a look at the top rhythm. And then look at the bottom rhythm. The bottom rhythm is an organized rhythm, correct?
Right.
Okay, so if we've got an organized rhythm, and this is all in one strip, same patient, it's organized on the bottom, but your lead 2 has all this other stuff in it. What's going on lead 2?
I don't know.
Artifact.
Okay.
Go fix the lead.
That makes sense.
Go fix the lead.
Okay, easy enough.
Yeah, you know, so, I mean, the important thing when you first see this, it'd be easy to jump to VFib, right?
Right. That's the QRSs are there.
Yeah, but you drop down to the bottom rhythm, and you've got an organized rhythm.
Okay.
You know, so look at the whole picture before you jump to any conclusions. So let's look at our bottom rhythm and what's our rate?
80. 1, 2, 3, 4, 5, 6, 7, 8, 80. Yeah.
Is it regular or irregular?
Irregular, a little bit.
It's irregular. Yeah, it is irregular. Very good. Do I have P's in here?
Not in that lead, no.
That's why you need to fix that top lead, right? So you can see
right.
the P's fibrillating.
So, right. Okay.
So what rhythm are you in?
AFib.
Exactly. So, you know, your clue here is that it's irregular. Those are fibrillating lines in there. That's why, like I said, but that's why you need to go fix lead 2 so you can be sure to see it. Okay? Next.
Okay.
And as I've said before, the main thing, this is a person in AFib with a controlled rate, so they're probably going to be just fine. Okay?
Okay.
Okay, Jess, thank you.
Thanks.
Jessica, next.
Are we going to get one similar to that we just got? This is Jessica. I didn't like that one.
I do not believe they have an artifact on there. I put it on there because I think it's important for you to keep that in mind. You know, if you have 2 rhythms coming across on one strip and one is organized looking and one is not, go check your patient.
Okay.
Right? Don't go just by that rhythm. When I used to be a preceptor and you know, it's going to reinforce going to your patient first, I know how to mimic VTAC on a lead on a stable patient. So always go and check your patient.
Okay.
Okay, let's take a look at number 13.
Okay.
What's our rate?
80.
80. Is it regular or irregular?
Regular.
Do I have a P for every QRS?
Yes.
Do I have a QRS for every P?
Yes.
What's that rhythm?
Normal sinus rhythm.
Perfect. Oops, I don't have a pulse.
Oh, then pulseless electrical activity.
Perfect. Next. So if it's PEA, what are you going to do?
You are going to pace them?
Well, you can try pacing them, but what happens with PEA is that you have electrical activity, but your heart isn't working.
Okay.
For some reason. So you really have to find the underlying cause.
Okay.
Right? So if you had a patient that came back from labor and delivery and they were in this sinus rhythm beautifully and all of a sudden you lost their pulse, what could be an underlying cause immediate post C-section that would cause this?
An embolism?
Or they were just in surgery, hypovolemia.
Okay.
Right? So you always have to find the underlying cause on these guys. Somebody coming right out of surgery, I look at hypovolemia first, and then I start going down the list.
Okay.
Okay? Yeah. Good job. Next. Eleanor?
Yes.
Okay. Let's take a look at this guy.
All right.
What's that rate?
It's fast.
Yeah.
I mean, was it 220? Did I count that right?
Yeah, you did. So it's really fast, right? And you can't really tell if for every QRS and a QRS for every P. And it's so fast, it kind of looks like it's regular, but you can't really tell if it's not.
Mm-hmm.
So what would you name this rhythm?
Is that SVT?
Very good. Why is it SVT?
Well, the atrial part of the rhythm is too fast, so.
Right.
That's the one that's SVT or atrial tech, right?
Yep, exactly.
Okay.
And so what we're going by is anything that's greater than 160, we're going to put under that big umbrella of SVT.
Okay.
Right? And then we're going to try to figure out why they're in SVT.
So would SVT be like on the chest? That would be the correct answer versus atrial tech? Okay.
Right.
All right.
Exactly. So let's say, let me give you a scenario. We're going to play around with this one a little bit. So this would never work on your oncology unit, but pretend this happens anyhow, okay?
We never really get this stuff, so.
But let's pretend you're an ER. And I am 22 years old. I'm a college student. It is end of quarter exams, and I've been up all night studying like crazy and drinking lots and lots of Red Bull because I have not studied enough. And I walk in and I tell you I've been feeling palpitations and a little lightheaded, and you hook me up to the monitor, and this is the rhythm you get.
Uh-huh.
Okay, so we're putting it under SVT because it's so fast. What are some of the things you could do for me?
I really don't know.
Okay, so you could try having me bear down, you know, things that might cause my heart to interrupt and slow, right?
Okay.
So you could try to have me bear down. One of the things that works well is to take a straw and plug the end of it and have them blow against it to see if it'll stop. The doctor could come in and do carotid massage, but the nurse does not do that. And then we could also move to adenosine.
Okay.
Do you remember adenosine from your ACLS algorithms?
Well, I haven't done ACLS, so no.
Got it. Okay, never mind that.
That just stops everything, doesn't it?
Right. It stuns the heart. It stops it, so it restarts itself.
Okay.
And it's so short acting that it really does work well. The dosing is 6, 12, and 12. You give it really, really fast. You have 20 cc's of normal saline to flush immediately afterwards, and you hold their arm up in the air, and you prepare the patient for feeling their heart stop, and you prepare yourself for seeing a whole monitor worth of flatline.
Okay.
And then their heart restarts into normal sinus rhythm. When it works, it really works well.
Okay.
Okay. Next. So on this one, they were able to do some really fancy diagnosing, and they got to atrial flutter, but we're sticking with SVT.
Okay.
Good job. Thank you.
Thank you.
Kristen, next.
Sorry, I'm here.
Hi, Kristen. You don't like this one, do you? Okay, let's break it down.
Okay.
Let's break it down. Is it what's the rate?
40, 30, 40, 40. 30.
Too slow. It's slow,
yeah.
Right?
Yeah.
Do I have a P for every QRS? Next.
No. I don't see it.
Okay. Exactly. There's your P waves.
Ah, got it. Okay.
Okay.
Next. Yep, I got it. So,
is there a QRS for every P? What?
But I don't have a QRS for every P.
No, you don't. Next. See, there's all your QRSs.
Right.
So it's regular, but these guys don't look like they're talking to each other, do they?
No.
What block are you in?
Second degree?
Third degree.
Third?
Third degree heart block. So let me ask you a question. Why did you say second degree?
Because I kind of felt that they were working with each other at times, but not completely disjoined. But I guess they are disjoined when they aren't there.
Right. Exactly. Exactly.
So
and this is your third degree heart block. Next, and you would pace this patient. So
got it.
When you're looking at your second degree heart block, you have P's for QRSs for most of your QRSs, but you're going to drop a QRS complex.
Okay.
Okay? But your basic underlying rhythm will be a sinus rhythm.
Okay.
It could be slower, but it's going to be an organized rhythm.
Got it. Organized. Okay.
Yeah. Okay. Okay, Kristen, good job.
Thank you.
Thank you. Next. Amanda, I haven't called on you for a while.
Hi.
Hi. How about if you take this one on?
That'll be great because I have some questions, I think, on this one.
Okay.
So there is a P, but it's barely there. It's really close to the QRS. The rate is somewhat regular.
It's 70, and it's regular. Next.
Yep. Let's see. And they look like they're inverted, kind of, on the top lead.
Next. Hold on a second. I'm going to get some clues here.
Okay.
Next. So there's your P waves. Next. Next. So see how close those P waves are to the QRS?
Right. So,
and you can't really measure the PR?
Well, that's what I had a question about, because can you measure the PR? I mean, from the beginning of the well, I guess not really.
Not really. I mean, if you do measure it, you can measure that from the beginning of the P to where it intrudes into the QRS.
Right.
But you're not going to have a normal PR interval.
Okay.
And if you think about it, where's that P wave originating? Way down in the junction, right?
Oh, right.
It's not originating up in the atria where it's supposed to.
Right. So with junctional rhythms, they're not always slower rate. I thought they were usually a slower rate.
Well, they can be really slow, but you can have accelerated junctional ones also.
Okay.
You know, so if you go by the definition of a junctional rate, a normal junctional rate is 40 to 60. Anything greater than 60 is considered an accelerated junctional.
Oh, so greater than 60.
Right. And you typically are going to check to see how your patient's doing with this.
Okay.
Okay. Does that make sense?
Yep.
Okay. Any other questions?
I don't think so. I cleared it up.
Okay, good. Perfect, Amanda. Thank you.
Mm-hmm.
Okay, Crystal, you're next. Oh, this is perfect, Crystal.
So there's no rate, really. You have two at the beginning here that looks like it was V-TAC that has progressed into VCO.
Exactly. Exactly. You got it. So what are you going to do for this person?
Defibrillate.
Right.
CPR.
CPR, defibrillate. What meds can you give?
Epi.
Mm-hmm. What's the dose?
Let's see, the heart's not dead, so half?
1 milligram. Full dose. Full dose. You're in VFib, full dose. What's another drug you can use?
Is it vasopressin?
Yes. Excellent. Yes, you can. I've talked to ER nurses that have used vasopressin. They said it works beautifully. What's another drug you could use? Amiodarone.
Amiodarone, yeah.
Right. And that's how much? 300, right?
Yeah, 300.
300. Next. So for my L&D nurses, my oncology nurse, and my med-surg nurse, this is one of those lethal rhythms that you have to identify. Are there any questions on it?
No.
Okay, good.
What is the dose for vasopressin? Isn't it 40 milligrams?
It's 40 units.
40 units.
Right. And the only reason you don't see it used a lot is that you have to mix it. And it takes too long when you're in a code situation.
Which one is that?
Vasopressin.
Thank you.
Okay, Crystal. Excellent. Good job. You're ready for the lethal rhythm. Okay, Irene. Next.
Yes.
Oh, this one's perfect for you. You want to talk us through this rhythm?
Okay. You have P waves.
Mm-hmm.
And every P wave has a QRS complex.
Mm-hmm.
The rate is 80 and it's regular.
Mm-hmm. Next.
So
next.
It should be. Uh-oh, you gave me the answer. Yeah.
So you've got an ST segment elevation. So it's a sinus rhythm with ST segment elevation. Yeah. Does everybody see how the ST is elevated a bit from the baseline?
Yes.
I'm going to take that as yes. So Irene, what are we going to do for this patient?
This is an a STEMI patient, because if it has an ST elevation, then it's a STEMI patient. So you take the patient to a cath lab?
Yep. And what's another treatment that they could possibly do for this if cath lab is being held up for any reason?
Oh.
Thrombolytics.
Thrombolytics, okay.
Yeah. I mean, that's an alternative based on what their history is.
Okay.
Okay. Thank you, Irene.
You're welcome.
Next. Jess.
You said Jess, right?
Yep, I said Jess.
Okay. I mean, it looks like VTAC.
Very good. And you've got a sinus rhythm leak going into VTAC, right?
Yeah.
Okay, now the patient is alert and oriented and talking to you.
Okay.
Okay. They have a blood pressure with this scenario. So how would you treat this patient? You could cardiovert, yes. What's a drug you could give me?
Amiodarone.
Very good. What would the dose be?
Is it still 300?
It'd be 150 because I'm a.
Okay.
You got a beating heart, so you cut it in half.
Oh, okay.
Okay, perfect. Good job. Next. Sinus rhythm to VTAC. One of the things to be certain of, this multiple choice, but be sure that if they've got an answer that says sinus rhythm to VTAC, you choose that one because you're identifying. Okay?
Okay.
Okay, perfect. Thank you. Next. Jess.
Hello, sorry.
Oh, no worries. Let's take number 20.
Okay, that looks like a flutter.
Very good. Excellent. Any questions, anyone?
Sorry,
that was a neat.
I didn't talk that one through.
Perfect. I mean, it's regular. Your atrial flutter can be irregular, but those are distinct flutter waves, and I believe the rhythm strip that's on the test is very sawtooth like this. Next. So good job. Atrial flutter right off the bat.
Thanks.
It's a 4-to-1. Next. And your main goal with this one is the same with AFib. You're going to be doing rate control if there's any issues. On this particular patient, you'd be looking to see if they're symptomatic or not. Good job, Jessica. Okay, next. Eleanor.
I'm here.
Hi.
Hi. I had a feeling I was going to get called on this one.
Yeah.
Let's see. 1, 2, 3, 4. So rate is normal. It's irregular. PV. There is a P for every QRS, but not a QRS for every P.
What's the PRs doing?
I'm sorry?
What are the PRs doing?
Well, it looks like they're getting longer, and then at the very end, they get short again.
So go in the middle, there's a short one, then it gets longer, and then longer, and then it drops, right?
Completely, okay.
Yeah.
So that would be second degree type 2?
Type 1.
Type 1.
Right.
That's when they drop the QRS, but it's type 1?
Yep. Well, what makes it type 1 is that your PR interval is getting longer, longer, longer drops.
Okay.
So anytime you see a pattern where the PR interval gets longer and then it drops the QRS, you're in second degree heart block type 1.
Okay.
Otherwise known as Winky Buck.
I was going to ask you, are they going to ask Winky Buck or type 1 or?
They want to know if it's Mobitz type 1 or Mobitz type 2.
Okay.
They sometimes will add Winky Block in, but your real identifiers is Mobitz type 1 or Mobitz type 2.
Okay.
Okay. Now, one of the things I want to point out to you, Eleanor, you did a really good job of identifying all of the components of the rhythm strip. And you knew you were in a block. You just weren't certain which one it was. And it's just a matter of memorizing that type 1 is the PR intervals get longer and you drop a QRS.
Okay.
Type 2, you'll go along in a normal rhythm and your PR intervals will all be the same. And then you drop a QRS.
Okay.
And you can drop more than one QRS. You can drop 1 or 2. But then when you go back and look at the underlying rhythm, your PR intervals are all the same.
Okay, that's type 2. Okay. Okay.
Okay. Next. And I think that's the one way of simplifying. That's just showing you all the PR intervals there and where you drop the QRS. Next.
Okay.
But I think that's an easiest way to keep in mind the difference between type 1 and type 2.
All right.
Okay. Good job. Thank you.
Okay. Thank you.
Kristen, you're next.
Okay.
Ew. Don't like this one. What is it?
VFib?
Exactly. This is VFib. You need to know this rhythm. Next. What are you going to do for VFib?
Let me think for a second. Okay, so we need to basically restart it. So, like, are you talking like med, like amiodarone?
No, yeah, amiodarone. So you're going to do CPR,
shock,
epi 1 milligram.
Okay, epi 2. Okay.
All right. Then you can go to either another epi or a vasopressin.
Okay.
And then you go to amiodarone, and it's 300 milligrams.
Yeah, because it's got it.
Got it? And you're doing CPR between each one of those.
Yep.
Their best chance of surviving is delivering electricity. So if you ever get a question that says, what's the first thing you do for a rhythm like this? It is getting electricity. You're going to shock them first. That's their best chance of surviving. Okay?
Okay.
Good job. Crystal. Next.
Okay. This looks like it has runs of VTAC.
Very good. That's exactly what it has. That's exactly what you have. So if you break this rhythm down, if you look at the first complexes, you have a single PVC. They're pointed in different directions. And then you have a 3-beat run of VTAC. All this tells you with the PVCs pointing in different directions is that it's multifocal, meaning it comes from the PVC is originating in different areas of the ventricles. But if you go past that first 3-beat run, your underlying rhythm is what?
Normal sinus.
Exactly. So I've had cardiologists tell me, don't call me until you have a 6 or 8-beat run. But as the nurse, you're going to check your patient and make sure that they're stable with this. Next. Good job. You guys are ready for the test. You know that? Thanks, Crystal.
Thank you.
Next. Irene.
Yes.
Okay, this one's yours.
Sinus tach.
Sinus tach, exactly. Can you walk everybody through how you got to sinus tach?
Okay.
Next.
My rate.
Mm-hmm.
Counted the rate. It's 1, 2, 3, 4, 5, 13 times 10 is 130.
Right. Right.
Then there is P waves to every QRS complex.
Mm-hmm.
And it's regular.
Yes. Makes it sinus tach, right? So what are you going to do for this patient?
You slow down the rate. You give them usually diothiazine or LAR, the beta blocker.
A beta blocker, right? Exactly.
Yeah.
Perfect. Thank you, Irene.
You're welcome.
Next. Jess.
Yes. It looks like asystole.
Very good. Next. Ventricular standstill or asystole. You know, if you stick with asystole on all of these, you know, saying whether it's agonal or ventricular standstill, or they all mean asystole. So what are you going to do for this patient?
CPR, epi.
Yep. Pace. Okay, very good. Thank you. Next. Jessica.
That one is VTAC.
Very good. What are you going to do?
You are going to CPR and maybe give an antiarrhythmic?
Shock first. Always shock first.
Shock first.
And then move to your antiarrhythmics.
Okay.
Always shock first.
Okay.
Okay, perfect. You're ready for the test.
I don't know about that.
Yeah, you are. Next. And next. Okay, Eleanor.
I know that's torsades.
Perfect. What am I going to do for it?
That I don't know.
You're going to give magnesium. That's the answer they want for this rhythm. This rhythm is on your test, and they want you to give magnesium.
Okay. I can remember that. Okay.
Okay, everybody, those are all my rhythm strips. Are there any questions or concerns before I give you some more information?
This is Amanda. Quick question, the magnesium, are they going to ask us how much? Because I forget.
4 milligrams IV.
4. Okay, thank you.
Yeah. I don't know if they ask you or not, but that's the answer.
Is the test timed, like a certain amount per question? This is Ellie,
No.
sorry.
No.
Okay.
It's not timed. In fact, you need to remember to take your time when you take the test. There's no rush to take this.
Okay.
You know, your main goal is accuracy and showing them that you know how to do this.
Okay, thank you.
Okay. Okay. Any other questions? Okay, get your pen.
One second. I did not get her question. Oh, sorry. This is Irene. I did not get her question, and you gave an answer of 4 milligrams. So 4 milligrams of what?
She wanted to know how much meg sulfate to give for torsades.
Oh, okay. Thank you.
You're welcome. Any other questions? Okay, get your paper and pencils out so you can make some notes. They want to know, you need to be able to calculate rates. So I believe on your first question, they're going to ask you, what is the rate of the question? You need to be able to measure the PR interval, the QRS complex, and a QT interval. You need to know second degree block and asystole. You also need to know sinus brady, sinus tachycardia, and what is the treatment. If you don't remember what we talked about, it is in your packet. Atrial flutter and the treatment. Once again, if you don't remember the conversation, study your packet. Identify torsades and what is the treatment. They want mag sulfate. VFib, and like I've said multiple times, your first treatment for VFib is shock. You have to deliver electricity. That's their best chance of survival. You need to know normal sinus rhythm. You need to know normal sinus rhythm with PVCs, which we've covered. You need to know second degree heart block and that it's Winky block or type 1. And once again, VTAC. All of the lethal rhythms are VTAC, VFib, asystole, pulseless electrical activity, and torsades. And I just got a message coming across on my Insta message doodah thing telling me that they do provide you with calipers. Okay, ladies, any questions?
You know, today I was calculating the rate, and sometimes when I checked on what the rate is, it will give me another rate that I won't think that it was. Let me say I had 6 PRs. No, yes, I have 6 Rs. I know that that's 60. But at times when the strip is not completed and I have 6 Rs, instead of 60, they will give me like 58 or 54.
Okay, so what that means is that, and this is in your packet, there's another way to calculate rates that requires you doing a countdown in the boxes on the grid. It is included, that method is included in your study packet from Inova.
Okay.
I don't have it in this presentation, that's why I don't talk about it. But that's how you're able to get to 58 or 54.
Okay.
Okay.
Do we need to know how to do it that way, or is it fine just to count the QRS complex like we've been doing?
It's okay to count the QRS complexes as you've been doing. Just remember to stay within the hash marks. So let's say there's 3 hash marks going across. Make sure that you start within the beginning hash mark and the end hash mark.
Okay. Thank you.
You're welcome. Any other questions? I want to thank all of you.
PEA, I'm sorry, this is Ellie. PEA treatment.
You have to find the underlying cause. You're going to initiate CPR and look for why it's happening. Because if you don't treat the like it could be trauma, it can be something, you have to treat that underlying cause. Otherwise, you're never going to be able to bring them out of it. In fact, my experience with PEAs is that unless you're standing there watching it happen, your chances of pulling them out of it are pretty darn slim.
Okay. Thank you.
You're welcome. Any other questions? Okay, ladies, you all are very well prepared. As we went through the rhythm strips, you got more and more proficient at it. Just keep that in mind that you do know these rhythm strips. Take time to study that study packet and practice, practice, practice. That's what makes you feel comfortable with this. And go out and pass the test with 85%. Actually get 100.
Thank you.
Okay, you guys. Thank you.
Thank you. Good luck.
Okay. Bye-bye.
Bye-bye.